I was teaching in Israel, and there were two parents that were parent effective trainers, teachers, and they had two young children. One 4 years old, little girl that did all kinds of things, and a little boy that was 7 years old, that they were working very, very hard to make him perfect, in the way in which PET people do. And I was suffering the other side of the mirror, seeing that, and then I wanted to enter. I was supervising I think that the therapist was Anita Bardin, and I go to enter into the room, and before leaving the observation room, there was a plate with cakes. In Israel, you see, there are no workshops without cakes. So, leaving, I took the plate with the cakes, not knowing why. I just took it. I entered into the room. I gave one cookie to the little girl. I said to the parents, I will not give you cakes. I gave one piece of cake to the boy and one piece of cake to me. And I said to the girl, you and me are imperfect, so we can eat and make crumbs. But to the boy I said, you're working very hard to be perfect, so you will eat the cake in a perfect way. The only way of eating the cake in a perfect way is not to make crumbs. And we began to eat, and the kid was puzzled and didn't know what to do. And then he says, can I eat? And I said, no, you can eat only if you don't make crumbs. So the kid, after a while, was a bright kid, looked at the mother and says, can I be imperfect?
Use that word? Can I be
Yes,
imperfect?
can I be imperfect? Now, what I could not understand is what moved me from I know that I took a prop. I don't know why I took a prop, but I took a prop. But when I took a prop, I didn't have any idea of what I would do. At the moment, between the less than a minute that took me to move from one room to the other, I came with something that surprised me. And then I had asked myself sometimes, how do I teach that? Is it teachable? Is it worth to teach? Can one teach the spontaneous ability to get data and to transform it into a creative move? And I don't know, clearly it's unteachable. I don't know from where it comes.
The problem is that often students then begin to make a cookie therapy or a cake therapy,
yeah,
where they serve cake to kids all the time.
Yeah, this is the Frank Pittman, what is it, the Cooker Spaniel therapy.
It is, I think, really a lot of the art of teaching is to set up a situation where an idea develops naturally, and it's always an unpredictable idea. I think lab supervision does that. That if you're behind the mirror, if somebody asks you about a case, it's hard to think much about what to do, unless you know the person's work very well. But if you're behind the mirror and you see him with a family, you immediately know what ought to be done. I mean, an idea just comes at that point. I think it's because your unit is the therapist and the family at that point, and an idea develops out of that.
Your observation is a wide lens observation. You watch the therapist and the family.
That's right. That's your unit, I think, as a supervisor.
And so what do you do? Means, how do you, let's imagine that this idea comes to you, or any other. Tell me about an idea that comes to you, and how is it implemented and modified by your supervisee?
Well, I'm watching an anorectic and her husband, and a therapist, March Ortiz. And the husband is one of these guys who's irritating. you just feel the women behind the mirror just don't like him. He's irritating in the way he deals with his wife. And he's busy trying to get his wife to eat and gain weight. So I can see immediately that anything we do to help her eat and gain weight puts us on the side of a man who irritates her.
Okay.
Then I begin to think what can be done about that situation. And I notice he's a little overweight. So I get the idea that we can ask him to lose the weight that his wife gains. Or even make a ratio. If he's got to lose 3 pounds for every one, however, we might do it. And I do this hoping that he won't lose the weight. Then we can get angry at him for not cooperating. He's being so dedicated about helping his wife, and he wouldn't even lose weight. And in that way, she will get out from under that burden of him being irritating and wanting her to lose weight. In fact, she'll begin to protect him by gaining some weight. Is what it is. And exactly that happened.
Okay. You know, I can understand your thinking. Now, there is 2 things that I would like to understand. One is how, from the point in which you develop this thinking that formally could be described even with a formula. But how do you make that intervention in such a way, first that your supervisee takes it, gets the same set of 3-4 movements ahead in his thinking, and makes the people follow him? Because that is what you don't describe.
Well, what I was working with was a woman I've worked with many years, Marcia, and I've supervised her for a number of years. So we collaborate very well, and it's almost like go with plan 2, and she goes with plan 2. But as soon as that was suggested, that the husband lose what the wife gained, she did it in a style that made it kind of a game, that was kind of fun, that got him involved, that got him a bit challenged, that dealt with putting the premise in that I know you want to help your wife and you're very concerned. So she began to motivate him to agree to this by hanging him on his concern that he had been expressing for his wife. It was in some ways a kind of a phony quality to it. But he said
A kind of a what?
A phony quality, that he wasn't as concerned. He was a busy guy, and he isn't as concerned about his wife and her weight as he says, but he says it like a proper guy who's concerned. So she hung him on that, really. I mean, she immediately saw she could commit him to doing this by using the issue of his concern. That is, she knew how to motivate him to do it. All I had to do was suggest to her that this would be a good idea to do. And she knew how to carry it out, but that was because she's done this for a long time. Now, a new student, I might have to talk to bring the student out and say the way to motivate this guy is to say that you said you were so concerned about your wife. Therefore, I'm going to ask something of you. So on.
Means you would teach him how to do that.
Yeah. How else would he know?
Well, I don't know.
How would you handle a similar situation?
See, I am trying to think if what do I do? Because it seemed to me that what happened is that you can initiate. For instance, you give a map. You gave to Macha a map that he should lose what she gains or something like that. Then, out of that, the way to motivate then begins, but it goes in unpredictable ways, because you cannot predict his answer, and in order to influence, she needs to be able to be comfortable that she initiates the dialogue, and that the man's answer will modify her next movement. And then you have a calibrating kind of thing. How do you do the dialogue in such a way that you accept his input that modifies the direction in which your next movement will go? So I think that it seemed to me that one of the things that probably you and Macha had was a kind of an acceptance of humor as as a way of, okay.
Particularly in anorexia, which is so grim. If you can introduce some humor, it helps no end.
Yeah, so that the thing that I think you teach, probably, I don't know, would be a kind of loose quality in the therapist that makes the therapist a participant in a game, and so that can accept the input and can accept. You cannot give a clear step by step. You give just a quality. I don't know.
It depends upon the therapist. Some you can just give the quality and they'll carry it out. Some you have to give them step by step. But suppose you were behind the mirror when the therapist was in the room on that cake incident, and you decided it would be a good idea for the therapist to do this with the kids. How would you teach him to do that?
I don't know. I don't know how to do that, because I didn't know before I went in that was a way of using the prop, and I absolutely, what I could say to the therapist is something like, it's tremendous how they want to make him perfect. Find a way in which the kid will ask for some degree of freedom, and I don't know what else would I say. I really am not very good in that kind of thing. I usually, when a therapist is stuck, I am triggered to enter, dance with the system, and leave. In some way, it is something.
But it's because you go in the room and I don't, so that I'm forced to think of things to do through the person indirectly.
Yeah, so that it's, in that way, I think that I am a little bit like Carl, that teaches, trains through co-therapy.
By example, really.
Well, not by example, because he doesn't teach by example. He teaches by a mood, by working together, by the development. I think that you also teach by a mood, or maybe not. You have more of a program. I know where I want to go.
In relation to the mood behind the mirror, I'm often teaching.
How so?
Well, I think I supervise differently if I'm alone behind the mirror supervising than if I have a group back there that I'm teaching. I tend to get more innovative when I'm teaching, because I'm explaining aloud what I see is happening and what ought to be done. And then I begin to realize, yes, that ought to be done.
Yeah, well, that happened to me also. The group acts as a stimulator, and one becomes more creative. Okay.
But that is it is a problem. Braulio Montalvo used to emphasize this problem of how do you teach somebody to innovate a procedure or a technique that's new, that you teach them how to innovate rather than you teach them your technique.
Well, for instance...
And that's the mystery I think we're all into.
Yeah. Let me tell you, for instance, that's why I had gone a little bit to teach concepts before teaching skills. For instance, I would say to my students, when a patient comes with a symptom, one of the things that we'll finish a session with is with the idea that the patient will acknowledge, and you will acknowledge the symptom, but give the responsibility of the symptom to somebody else. So the idea of the yin-yang, the idea that people are the context of the other, then it becomes like a goal. In this session, you will need to find a way of making the behavior of one member acknowledged by this member, accepted, but he is not really the one that controls his behavior. So that you can say then to the person that is not the patient, change him. And then when the person says to you, what do you mean change him? I cannot change him. He can only change yourself. Then you will say, no, nobody can change oneself, but you can change him. And I explain to the student the fact that if two are one and one is the context of the other, that the only way in which one can change the other is by modifying his behavior in relation to the other. And in some way or other, that needs to happen. But I don't know why. I don't know how. I know why. So then it is a kind of a formal map. Something, a change of that nature will need to occur and will be done tailor-made in every session, because while one knows the map, one doesn't know the ingredients that the family will present. So that if the woman comes and she's anorectic and the man is there and he's a little bit overweight, then the student will know that in some way her anorexia is controlled by him. That means that is, and that he can change her anorexia, for instance. And then the question would be, in what way can the student make that connection? And maybe the student will say something similar to what you said to Macha, that, it seemed to me that both of you have one body. And one of the ways, and she needs to be thin because you are overweight. One of the things of changing the body is for you to lose so she can win.
Well, would you recommend that be said to them?
I don't know if that will be said. You see, I am saying that if you have the formal map that there is, that in some way or other, all therapy is a change in the epistemology of people, that this change need to be clearly formulated for the therapist, and it doesn't need to be formulated for the family, but the therapist need to have that.
This is where the problem for me comes.
Okay, so we have a difference. Good.
Well, I'm not sure it's a difference, but here's the problem I see. I think the way you deal with a therapist tends to be the way they deal with a family. So if you say to a therapist, conceptually the issue is that there's only one body between husband and wife here. It's very difficult for the therapist to go in, make a game about the husband losing weight and the wife, without giving them that concept, without saying that to them. Because you tend to carry into the room. That is, it's very difficult to have an insightful conversation about a therapist behind the mirror and have him not go in the room and he's got to be insightful with the family.
Well, you see, that is not true, and it is true. If you work very close to the supervisee, then that will be true. That means that your relationship with the supervisee and the relationship of the supervisee with the family will tend to parallel each other. But if you relationship, if for instance, if this concept is a concept that is not part of life supervision, but is part of the videotape supervision, and it is a concept that becomes one that the group plays around with, so that when it happens, when the supervisee enters into the room, he is not responding very close. See, I think that the relationship between the supervisee and the supervisor that you carry is a very close one, similar in some way to the Milano team supervisee relationship, that I think that ties the member of the team very much to the thinking of the team, and in your case, ties your supervisee very much to your thinking. I think that in some way I have more of a distance. The fact that I also enter and participate as a co-therapist makes my relationship one that is not as close as yours.
Well, that may be.
It's an interesting formula.
You enter with them.
No, but it's not one in which he hears my voice.
But I'm thinking of it this way, that one of the reasons I don't like to give people awareness or insight in therapy, because I think they don't like it, and they'll get revenge by not improving on it. And that you tend to arouse resistance. For example, if you say to the husband and the wife that you only have one body, I think you may do that in order to get them to prove to you they're separate individuals. I mean, that would be a calculated way.
Well, then,
But to give a conceptualization to them, I think interferes with the therapy. At least that particular maneuver of getting the husband to try to lose some weight while the wife gains it. But here's the reason I don't like the idea of therapist training to include personal therapy for the trainee, unless they have a problem and they need therapy. But to have the idea that that's going to make them better therapists, I find them more difficult to teach. The more therapy a trainee has had, the more difficult they are to teach. And one of the reasons is because usually that's an insightful therapy. They're learning about themselves and understanding themselves and so on. And then they get in with a family, and the trainee feels like a cad if he found that valuable in his personal therapy, if he doesn't do the same with the family. So he starts helping the family gets irritated with him, and he compounds his problem.
But you see, Jay, here I think that we do differ quite a lot. Because I don't find that people, in my influencing people, in my meddling with people, in my carrying people with me in the direction of change, I do develop a collaborative relationship with people in which I do all kinds of things. Cajoling, seducing, teaching, being a wise person, using humor, teasing, all kinds of things. Saying to people, it's a rather interesting and strange thing that you two seem to have one body. It's something I will say, and I use a lot a language that says, it is very interesting, it's extraordinary. And then with that kind of exclamation points, I would introduce ideas like that. I never found that people respond to that with resistance. I find that one of the ways in which I take people to shave their head, like Chloe did, is through a variety of maneuvers in which I am friendly and teasing and distant and pushing and all kinds of things. Among them, explaining is one of them.
But there's two things about it, I think. One is the explanation you give them, I don't think is necessarily a truth of some kind. It's an explanation that will help you get them to their destination.
That's correct.
Whereas, for example, I think some people who are trained who will misunderstand what you're doing. And they'll say to the mother, have you noticed that you're overprotective with your child? A mother doesn't like that kind of a comment. In the first place, she knows if she's overprotective. And this is like rubbing your nose in it. But to have that imposed upon her does make her begin to expel the child, to begin to get irritated with the therapist. And the therapist thinks he's being helpful, but he's not really thinking of the destination of the woman and the child.
But this, I think that at the point in which you teach a student an orientation that is an orientation toward the goal, means the therapy is a therapy in which people, from the beginning, the concept is a concept of change. Then the interpretation, whatever interpretation it goes, becomes a comma, a semicolon, never a period, because it is an interpretation that moves people toward the goal. My teaching, like your teaching, emphasize that what we are going to do is to produce change. So that, and I think that I had found the introducing a set of significant concepts about the process of change helps the therapist to develop a frame.
The difference is, though, that I think it's in the theory of change. I think the people who tend to make interpretations and help people become aware think that will change them.
That's correct.
They don't see this as a step toward getting them to do something that will change them.
That's why I'm talking
And
about
that's one of the
a goal.
right?
At the point in which you have a teaching that is a goal-oriented teaching, in which you said, okay, one of the issues about this anorectic person is, and about this obese man, is that something will need to change in terms of her obsession about not eating and the way in which he responds to her that maintains her not eating and blah, blah, blah. Then, I think that...
You know what I'm reminded of? I learned a lot from training those people in the community. Because I think therapy came out of educational institutions. And educational institutions are full of intellectuals who think that awareness, knowledge of oneself transforms oneself, and so on. And when you train people off the street, they really don't have that idea. I remember Pete Urquhart had a mother who never she had a 12-year-old son that she never let out of the house because possibly he was retarded or whatever. Not very, really. She walked him to school. She volunteered at lunchtime, so she watched him in the schoolyard, and she walked him home after school, and she kept him in the house. Now, she described this to Pete. He never once suggested that she was in any way overprotecting the child. And he began to say, a kid his age really should begin to learn how to be out on the street. Do you suppose you could sit on the front porch while he was just on the street right in front of you? She said, yeah, I guess I could do that. He then got that kid out in the street, had him down playing basketball within 2 or 3 sessions, with the woman very pleased. Now, if he'd said to her, you see what you're doing, you're restraining this boy from going out, you're overprotecting him, you're keeping him, that is, if he helped her understand what she was doing to the boy, as many therapists would have in those days, I don't think he would have had anything but trouble with this woman. Now, what interested me is that never occurred to him. He didn't think that pointing anything out to this woman would change her.
Yeah, but you see, it never occurred to him because in this culture, that's not what people do.
That's right.
So that he did the kind of thing that was absolutely correct to make the woman change.
And in the intellectual culture of the university, that's the way you learn to do, is to point out to people what they're doing so they'll understand themselves.
But then the question is, how do you then, if you're working with people with different cultures,
Sure.
You do use, and if your goal is to help them to behave differently, you enter through the avenues that are more available, so that some of your students may find families that demand a kind of an explanation for
Sure.
in order to change.
Well, in families that have had a lot of therapy and expect to
then
be
you do that.
insightful, we give them insight
Yeah.
because they think you were strange if you didn't.
That's correct.
But that's done as a step toward a destination, not on the assumption that's going to change them.
Yeah, but
Sure.
you see, we are then talking about what kind of generic concepts the student therapists need to have to become innovative and to develop tailor-made kind of interventions. I think that there are certain things that facilitate that, and that the student need to be, the therapist, the trainee, need to be ahead in that game, ahead of the family, so that can intervene and lead the family. My feeling is that that has been a change in my teaching, that I was much closer to teaching behavior and inductive, and that I have today a number of generic concepts that I teach that I think facilitate that particular thing, how to innovate.
I'm not against helping a family conceptualize the situation if it doesn't interfere with the therapy. It's just that I think it can interfere if it slips in the idea that that kind of conceptualization, that aha of the family realizing what they've been doing is a cause of change. You know, I keep thinking in the back of my mind, I'm still thinking of that cake incident you were talking about, and how you walked in the room without a plan. Because it's so similar to a case of Erickson's. I have these conversations, and Bates and John Weekly and I were talking to Erickson, and he told us this case. It was an adolescent girl. The mother came to Erickson and said, I have this adolescent daughter, and she's suddenly withdrawn from the world. She won't go to church, she won't go to the movies, she's refusing to go to school. She said her feet are too big, and I can't get her even to come in and see you because she won't leave the house because her feet are too big. So Erickson said, well, I'll go see her. And what I'd like to do is I'd like to go with some excuse to your house. So why don't we say that I go and give you a physical examination, that you're not feeling well, and I'll give you an examination. And she had said she wasn't feeling too well. Bateson immediately said, well, aren't you deluding somebody about whether she was not well or not, tricking the girl? And Erickson said, well, the mother was a little doubtful about her health. So Erickson went to the house, and he did a physical examination, asking the daughter to assist him. And she stood beside him, and he had to go get a towel, and he had to do this and that. And she was concerned about her mother. The doctor was examining. And he said that he went there, and at that point, he didn't know what he was going to do. But he thought, if I get in that situation, I'll think of something. Mm-hmm. So what he did was, when he had the girl right beside him, he carefully stepped back very hard, right on her foot, and she yelped when he stepped on her foot. And he turned around very angrily and said, if you would grow those feet big enough for a man to see, I wouldn't be in this situation. And he turned back and went on with the mother. And he said that was a message about the size of her foot that she in no way could reject, you know. And he said that he examined the mother, chatted with her a while, left, and that afternoon the girl asked the mother if she could go to the movies, and she began to go out. But what impressed me about the similarity was that he didn't know until that moment. And I remember Bateson saying, you must have planned this in advance. And he said, I didn't have any idea until I got there.
Yeah, absolutely. The question is then, what kind of schemas do I have that I developed through my years of seeing people that help me? I trust myself a lot now. I know that something will occur to me that will connect certain plans with what you tell about Erickson. I would be operating very much the same way, knowing.
The problem, though, is how do you teach somebody to do that?
Well, that's
what the real art.
That's what I am saying. First, I would need, to know what kind of labyrinth do I have that facilitate this kind of thinking, and that is one of the things that I am exploring, thinking that there are a number of things that are rather generic, that can be umbrellas that help you to connect certain things. Because one of the things that I know about myself is that at the point in which I develop a metaphor in a session with a family, then I tend not to hear and not to see things that are disconnected from this metaphor. Mm-hmm. It's a kind of lovely things that happen to me. I just become very connected to one idea. and everything gets connected to that, like what you said about Erickson. He comes and he knows that he will need to do something that is related to food, that is related to size, that is, and he doesn't know what. And I think that these things then are possible to teach.
And he also knows that he has to go there because he's not going to get her in with that problem.
Yeah.
So he's got to do a home visit. Well, one of the things that interested me in reading these conversations is, but we were in a period where we were interested in homeostasis, naturally. And Bateson said, what about the mother resisting this improvement in the girl, or preventing your success with the girl? And Erickson said, how could the mother prevent anything? She didn't even know what happened. All she knew was I was rude to her daughter. That is, he gave them the mother no conceptualization of what he was doing at all. He came in there and made that change. The mother was surprised that the girl wanted to go out to the movies that afternoon.
But it's also, to me, there are two issues here in your story. And one is that Erickson expects people to follow him.
Absolutely.
While conceptualizing resistance and avoidance of resistance and so on, there is something about his trust that these people will really follow him. So that...
Well, actually, he was unhappy with our way of conceptualizing homeostasis, resistance, because he heard it as resistance. And his idea came out of hypnosis, really, that if you expect resistance, you get it. If you don't anticipate any objection by the parents, you don't get it. And I find myself with students today irritated in much the same way when they start talking about families resisting change or parents resisting change, because I can see them producing it by the very act of anticipating it.
Okay. Then, for instance, I don't expect resistance, but I always expect inertia.
Inertia? That's a good way to put it.
I said to people, if you are going to ask an organism or an object to move it, you will necessarily need to have inertia. So that is something that you need to
people tend to continue doing what they're doing.
If you don't have it, something is wrong. That's resistance. If you don't have inertia, if people do immediately then that's resistance. That's wrong. But you expect inertia. The other concept that I am saying is people always can. I have one of the concepts that I really teach is that people always can do more than what they are doing. That this is a generic. When people tell me, well, what if they don't? I said, what if they can't? What if the mother cannot? And I said, in my experience, I had never found that somebody cannot expand. So that we live in a rather narrow set of use of our possibilities, and we have many other possibilities that we don't use. So that one of the things is a rather optimistic view that I impart my students, that people can do more and can do things differently. So,
and that they're willing to.
And that they are willing to.
If
Yes,
you phrase
absolutely.
it in a way that seems reasonable, they're willing to do it.
Okay, so, these kind of things one teaches. I also show, and I in the videotapes we discuss and so on. But so that there are certain concepts that seem to me that it's possible to teach.
You can, sure. One of the things you're after in a trainee is to get them into a stance where they expect people to cooperate, expect people to change, assume that people are there to change, not to resist.
Okay, but you see, in that thing, we are very different than the people that expect resistance, then give a paradox that they expect will be resisted. Mm-hmm. What if a paradox is not resisted?
That depends on how you give it.
Well, of course, it is absolutely the way in which you give it. If you want to give a paradox that should be resisted, you do it in such a way that is resisted. But the student, then many students, then take this idea that people will resist you, and the Milano teaching is really, does not include the fact that the paradox is because one had created a context that will produce resistance.
One's created a relationship with them where they want to prove you wrong, which is not necessarily the routine therapy relationship. Yeah. It's a special one for paradox.
Yeah, and I think they do it very well.
Sure.
But I expect people to cooperate with me, and the kind of teaching that I do is a teaching that emphasizes that the therapist and the family are entering into a collaborative endeavor.
One of the things that I think we're beginning to teach more, or figure ways to teach, is I think a family responds well if the therapist is really interested in them. And some therapists are naturally really interested in people. Others almost have to be taught to be really interested, you know. That they begin to look at somebody in a way. I mean, you can say to them, to a trainee, well, is the mother left-handed? And he's got to stop and think. And if he doesn't know whether she's left-handed or not, he hasn't really paid attention to her in the session, you know. And that is, you can begin to do things to get them more observant. You can have them watch a tape more. But how you just get, even just talking about it, a woman like that, why would she do a thing like that? You know? Then they have to speculate why. Then they go back in and they talk to the woman with more interest in it. You know? That's a problem in how to teach that, because it's a natural human interest.
Isn't that the kind of thing that Carl Whitaker really had introduced very much into...
Well, Carl is really interested in people. That's right.
Carl is interested in people. And he relates with curiosity, proximity, personal response, that is very different than the idea of neutrality. You know, Carl is not neutral at all. No, I am never neutral. Sure. I don't believe in neutrality. I don't think anybody is neutral if you are in the process of helping people to change.
There is something about training, too, that it's so obvious that we take for granted that many people don't. And that is that therapy is best taught by observing a therapist at work, either on videotape or live, when the vast majority of therapy is not taught that way at all. You know, one of the things I realized was that the live supervision started in the 19th century. That in that very innovative period among the hypnotists, the way they taught hypnosis was the hypnotist trainee watched the teacher work with the patient and hypnotize them. Then the teacher watched the trainee do it with the patient and guided them. So it was all live observation.
I didn't know that.
Yeah, that's the way hypnosis is still taught. And then when Freud made an issue of giving up hypnosis, he went to the confidentiality of the room so that nobody could watch anybody doing anything. Students never watched teachers. Teachers never watched students doing therapy. And it was 50 years. It was up until the 1950s with the one-way mirror before people began to watch therapy again.
Because, you know, it's interesting because all the medical teaching is done, if you want, as live supervision.
That's right. It is live supervision.
It is the grand rounds, it is the teacher doing things, it is the student doing things, and the teacher observing. So it is the model of teaching. So it is only in therapy that the teaching then took that detached...
I think so. I think when Freud, with the power of his ideas in his organization, when he just took the field out of hypnosis, he went into the private office, which was much more important than giving up hypnosis, because nobody could watch him work. Everybody then had to just hear reports about what happened.
Well, it is in the consultation or in the supervision. Yeah, the supervision then became a supervision about events that occurred.
Or carrying notes across town to a supervisor and talking about what might have happened. You know, I was talking in New York one time, not long ago, to a large group. And I said, you know, we've changed in supervision so much that we used to take notes across town. And then the audio recorder was discovered in the 50s. When we began to audio record, we could have a trainee listen, or a supervisor listen to a trainee by audio. Then we had video, and we could actually watch it, and we also had live observation. So there's been great progress in supervision. And after I finished talking, 2 or 3 of the people came up and said, you know what we're doing here is we're still carrying notes across town.
Yeah.
And that's the way supervision is still done in that way.
I don't know why it's still done mostly. Why is that live supervision didn't
It's too
spread?
expensive.
It probably
It is it's the most expensive way to train. I think it's the most efficient in the long run, but it's hour by hour. Our place in Philadelphia are the only 2 places that I know of where a trainee is supervised every hour of the therapy. Some do it the first hour, and then they have them go off and see the family for a few weeks and then come back again. And we do hour by hour. And that is expensive.
It is an expensive way of teaching, yes. Yeah.
But it's the only way to be able to guide somebody at the moment they need the guidance, rather than saying later, you should have done this or that. It's immensely valuable, I think, but very expensive. And I think a part of the development of it was our work in Philadelphia, particularly with the community therapists, that we were worrying about protecting the families from people who were so just beginning, such novices.
Are you saying that the child guidance clinic was one of the first places that developed live supervision in the grand?
Well, you know, I was trying to remember this because somebody was asking me where it came from. And I remember in California, in the 50s, we discovered this man, Fulweiler, who worked in a one-way mirror room. He had been teaching psychologists to test by watching them through a one-way mirror with delinquents in this juvenile hall. He then began to see families, and he saw them in that room, and he would go behind the mirror and come out. So we came over when we discovered him, and I watched him go through a whole series of interviews. And we realized the value of that one-way mirror. So we built one where we could watch the therapists instead of just audio record. And then we had so many visitors.
When was that?
You know, somewhere in the late 50s.
Okay.
Fulweiler we discovered in 57. So we must have had that mirror in by 58, if not in 57. And then people came to visit, and they assumed that the one-way mirror was part of doing family therapy. And everybody began to put in one-way mirrors, and everybody for the first time in 50 years began to observe therapy, and it was interesting, you know.
You know, the way in which we did it at Wiltwig was us copying what teachers used to do in observing children in nursery schools. I have been observing as part of my training as a child psychiatrist.
And most child psychiatry places had mirrors, that's right.
Yeah.
You
So
just watch children. Yeah.
to watch children, so that when we decided to do family therapy and we didn't know what it was, the first thing that we did was to build a one-way mirror in order to learn from each other. So that...
Well, you also used the one-way mirror in a different way than anyone else. When you put part of the family behind the mirror with the therapist, and the other part in the room with the therapist, and use that like a membrane. That was a new way that I was interested in that when I was traveling around.
You know, the new ways become new ways because we didn't know any better. At the point, one of the problems of new people is that so many things had been already discovered and implemented that the discovery of new wrinkles becomes more and more difficult. So,
well, I think part of the reason that you could use it was because you were working with the poor.
Oh,
there was such
a lot of freedom.
There was such an issue of confidentiality with middle class. But the poor you could do anything with. Yeah. And therefore you had the freedom.
This is rather tragic, but it's true. There was only accolades about our work with the poor. No criticism at all. Mm-hmm. You know, because it's possible to innovate.
Sure.
When you enter, hospitals have been doing that for a long time. to work on the poor,
Sure.
and to learn on the bodies of the poor, and so we had that freedom.
Also, though, that I think you innovate dealing with cases that other people don't want.
Yeah.
Dealing with schizophrenics, we could innovate because other people didn't really want to deal with those people. And I think that was true of the poor, too. But that mirror, I think, transformed therapy because for the first time in many years, people actually saw what a therapist did.
Mm-hmm.
And I was reasonably, we were filming therapy, and it was so expensive because we had to use 16 millimeter. And we mostly audio taped. But I was finding out more and more that people didn't want to be filmed or audio taped. Not because of confidentiality reasons, although they said that. It was because they didn't do what they were supposed to do. They didn't do what they said they were doing. And the discrepancy appeared. If you did a film of what an analyst actually did, he wasn't doing what he was supposed to according to analytic practice theory. So they were very uncomfortable about being watched. And it wasn't only us, other people who were trying to film were running into that problem. But with families, somehow it all just opened up and it began to be accepted as that's how family, partly I think because families are interesting to watch, individuals aren't.
Yeah, yeah.
The real dramas are in the family rooms.
Probably it still remains that family therapy and videotapes and one-way mirrors are together.
Yeah.
This is the way of training, this is the way of supervising.
That's where you're concerned with skill.
Yeah.
Rather than just a personal nature.